Okay, so those are two of the tests that I will now move on to the Stenger test, and we're going to change direction now a little bit, because now we're going to think about patients who might be seen to be suffering or exhibiting non-organic hearing loss or functional hearing loss. And in particular, this is a non-organic hearing loss that's exhibited in one ear only. And these relatively commonplace in groups of non-organic hearing loss patients, for the simple reason that having hearing loss in one ear can provide an explanation as to why someone might still respond to speech or to everyday sounds that might not be expected to be heard, given the thresholds that they're exhibiting. And so the test itself relies on a concept known as the Stenger principle. So in this test, two pure tones are presented simultaneously to each ear, one to each ear. And the Stenger principle relates to a binaural interaction of these two sounds that are presented one to each ear. And it's such that if there is a difference in the intensity, then the individual will only be aware of the louder of the two sounds, so the higher intensity one. And despite the fact that the lower intensity one is physically present in the ear, they will have no idea that it's there. They won't hear it. So I've just provided here a very simplified audiogram to run through the concept of the Stenger test and how it works based on that Stenger principle. So what we have here is it's just of course just thresholds that I've input, so flat audiogram on each ear by AC, and we can see the true thresholds in the left ear are on the 0 dB HL line, so normal, and on the right ear the red thresholds, the red circles, are also normal. But what we can also see on the right ear is these green thresholds, these green circles, and these are the circles, these are the thresholds that the patient is providing. So that this is a non-organic hearing loss. It's not a true audiogram. There's some reason, perhaps psychological reason or other, as to why they might be exaggerating the hearing loss, and in this case they're exaggerating it to 60 dB NHL. And of course there might be reasons, perhaps information that the patient provides in the history, or some pattern to their responses to the audiogram, which might make one wonder whether or not there's a non-organic component to the loss. And in that case, the Stenger test, if it's a unilateral pattern like this, can be invaluable in identifying whether that is the case or not. And so the procedure is as follows. So as I mentioned, it's a binaural test, and there's two tones of the same frequency, and the tone in the good ear is presented just above its threshold, and the tone in the poor ear, or the given threshold, is just presented but just 10 dB below its threshold. And then at this point, due to the Stenger principle, one of two things will happen. We might end up with a negative Stenger, in which case the patient responds to the sound, they've heard it in their good ear, and that means that the hearing loss was genuine, there was no non-organic component to it. Or it might be that we have a positive Stenger. What that means is that the patient heard the sound, but they had to present as if they hadn't heard it, and they didn't push the button, and so we have a positive Stenger here. So I will just elaborate by returning to our audiogram exactly, just to unpack some of those bullet points right there. So here we have the first of those two scenarios. This is the same audiogram as we had before, but this time it's genuine. So we have a genuine flat loss at 60 dB HL in the right ear, and we don't know at this point that it's genuine. We suspect perhaps that there's a non-organic component to it. So we decide to revert to our Stenger test, and these stars, these black stars, illustrate the stimulus setup. So in the good ear on the left, it's just above the pure tone threshold, and in the poor ear on the right, in this case, it's 10 dB below the pure tone threshold. Now, since on the right ear the sound is below the threshold, they won't hear the sound in the right ear, the patient. But since the sound is just above the threshold in the good ear on the left, then they will hear that sound, and so when the sound is presented, they'll just push the button. There's no need to re-instruct the patient. There's no need to even tell them that the Stenger test is being provided. You can just seamlessly run into this test from the routine pure tone audiogram. And so if this is a genuine loss, like I'm showing here, we see a negative Stenger because the patient pushes the button to indicate they've heard the sound, and here they would have heard it in the left ear. On the other hand, this is the audiogram as per the non-organic component. And so here we have the same stimulus setup as before. So it's 10 dB below the given threshold in the right ear, and the given threshold was 60. So the stimulus level is 50 dB HL in that ear. But their actual threshold was 0 dB HL. So the person is hearing the sound in the right ear at 50 dB above the pure tone threshold, whereas they're only hearing it in the left ear at 10 dB above. So it will be substantially louder in the right ear than the left ear. And due to the Stenger principle that I mentioned, whereby if you present two sounds of different intensity, then the person will only be aware of the louder sound, then at this point the patient will have no idea that there's a sound being presented to the left ear. They're only aware of the sound being presented in the right ear. But of course they've already indicated that they can't hear that particular sound, and so they will have to go on indicating that they can't hear the sound, so there'll be no button press, and so there will be a negative response, and so we would call that a positive Stenger. And that would indicate to us that the thresholds that were provided on the right ear were in fact not genuine thresholds. So that's a very useful test for quick identification without the need to, as it were, draw out the patient and challenge them, because you can move seamlessly from standard pure tone audiometry into that test, and that can be useful from the point of view of managing cases of non-organic hearing loss. But while you can identify the presence or absence, you can take the procedure a little step further and start to plot the extent of the non-organic component, and that can be by turning the sound up or down in the poorer ear until you get to the point where they do respond as they're hearing it in the left, in the good ear, in the left ear in my example, or not. And so you can begin to plot the true threshold. It's not, as far as I know, commonly used, that particular test, but it's called the minimum contralateral interference level. And normally it should be below 20 dB above the threshold in the poorer ear. So there's three tests that we've gone through, looking at different areas of diagnostic routines that might be applied in extension of the pure tone audiogram. And now I'm just going to cover another three, but these three are going to be grouped together under the general subheading of tests for retrocochlear lesions. So there's three. There's the tone decay, alternate binaural loudness balancing, and the short increment sensitivity index. Now, when I say retrocochlear lesion, then what I refer to is, I'm just generalizing here, that there's a range of different retrocochlear lesions that we could talk about, but what I specifically refer to is a space-occupying lesion, such as a vestibular schwannoma. And so on the left here we have a scanning, an MRI scan. We can see we just use this is the good ear on this side, on the left-hand side of the page, and so you can see the image of the inner ear here, and the auditory and vestibular nerves as they go along the internal auditory canal and then join through the cerebellopontine angle to the brainstem. And on the other side, again, we can just see parts of the labyrinth here, and that'll be the cochlea there. But what we see on this side is a lesion that's growing in the internal auditory canal, and that's a vestibular schwannoma. I'll just circle it there. So a space-occupying lesion which has a number of effects on the affected side. So it will compress the nerves that run through the internal auditory canal. That's the vestibular nerve, of course, the cochlear nerve, as well as the facial nerve, seventh nerve. So the nerves there become compressed and distorted, and there might be other effects as well, such as reduced blood supply to the labyrinth, all of which can lead to a range of hearing and balance consequences. And the normal pure tone audiogram can tell us whether or not there is a hearing loss. Of course, it can explain the degree of hearing loss, its severity, and it can differentiate between a conductive hearing loss and a sensory neural hearing loss, but it can't differentiate between a sensory loss, which is said to affect the cochlea itself, so the hair cells that we were talking about earlier, and a retrocochlear loss, such as a space-occupying lesion, as we're showing here. In that case, one requires further tests, further diagnostic tests to differentiate between a sensory and a neural or retrocochlear loss. There are a number of these tests. A very common one will be, of course, the structural scan, the MRI scan, just like we're showing here, and that's highly sensitive to a space-occupying lesion. But there are groups of patients who can't have such a scan. For instance, patients who have some kind of metallic implant, perhaps they've had screws to mend broken limbs, perhaps they're claustrophobic and they can't tolerate being inside the scanner, or perhaps there are other reasons such as obesity, which means perhaps they can't actually fit in the scanner. So there are a number of reasons when the scan, like we're showing here, isn't suitable, in which case we might need to revert to other tests at our disposal. And the three that I mentioned, the short increment sensitivity index, the tone decay, and the binaural loudness balancing fit that group. So we'll go through tone decay first. What I'm displaying on the right there is an audiogram, the type of asymmetrical audiogram that you might expect in someone with a retrocochlear lesion like was shown on the previous slide. Although the pattern on any individual is highly variable, it's quite typical to see a high frequency loss like this. And the reason is because in the left ear here, of course, and the reason is because of the way in which the neurons of the auditory nerve are situated, with those that respond to high frequency sounds are on the outside of the nerve bundle, and those that respond to lower frequency sounds are more towards the center. So as you get a space occupying lesion, it's likely to affect the high frequency fibers earlier. So if we see a sloping loss or other type of asymmetrical loss like this, then it might be necessary to rule out such a condition. And one test that can do that or help do that is the tone decay. And what you would do is you would here we're testing at 1000 Hertz, so you would present a sound just above the threshold at that frequency. So the threshold in this case was 30 dBHL, so we present a sound at 35 initially, and we would increase the sound intensity until the patient first heard it. So we're going on an ascending run effectively, and the instruction is to hold the button down for as long as they can hear the sound for. And so we can see the result here, this yellow trace. So the patient detected the sound here in this hypothetical example at 50 dBHL, and they heard that sound for around about 30 or 35 seconds, and then the sound for them decayed. They could no longer hear it after those few seconds. So then what we did was we turned the sound up again, and then the sound became audible again, and then the patient held the button down for as long as they could hear it. So the sound goes up in increments, and we keep going up in increments until such time as the patient can hear the sound for 60 seconds. And under normal circumstances, so with no retrocochlear lesion, then that should happen very quickly. In other words, we should only have to turn the sound up by a small amount above threshold for them to be able to hear the sound for a long period of time, like 60 seconds. So the difference between when we first commenced the sound here, 35 dB HL, and the final level that was required for them to be able to hear it for 60 seconds, here in this example 65 dB, that's the amount of decay that we classify. And under normal circumstances there should only be a small amount of decay, so perhaps 10 dB or so. If it was a cochlear loss, again there should be a relatively small amount of tone decay, perhaps worse in the high frequencies, but nevertheless a smaller amount. Whereas with a retrocochlear loss, like the vestibular schwannoma that we were showing a moment ago, then tone decay is excessive, so greater than 30 dB, and this is because of the features of the pathology that I mentioned: compression of the nerve, distortion, and reduced blood supply, meaning that sensitivity to the sound can't be maintained for a long time until the sound is sufficiently high intensity. Related to that is another test known as the short increment sensitivity index. And this is a measure of one's ability to tell the difference between the loudness of sound. So that's what's meant by the difference Lyman for intensity. And so in this case, what happens is that we take advantage, if you like, of the increased sensitivity to loudness changes that you get in cochlear losses, and that's due to cochlear recruitment, outer hair cell dysfunction. Whereas in someone with a retrocochlear loss, we don't expect that degree of cochlear recruitment, and so they'd be less sensitive to changes in the loudness of a sound. So here the procedure is that we would play a sound at 20 dB, so a pure tone sound at 20 dB above their threshold, and then we would turn the sound up in small increments. Initially we'd turn the sound up by 5 dBs, but then after that we would just turn the sound up in increments of 1 dB at a time. And each time the patient heard that increment, in terms of they would detect a change in the loudness, they'd be asked to push the button. And what we would do is we would take note after 20 increments of the sound, 21 dB increments, we'd take note how many out of those 20 did the patient actually detect. And if they had cochlear recruitment, we'd expect them to detect many of them, and if they didn't, if it was a retrocochlear loss, we'd expect them to detect fewer of those increments. And we'd express the score as a percentage by taking the number that they detected out of the original 20 and then multiplying it by 5. And so if they scored highly, again, just to clarify, so that would be consistent with a cochlear loss, whereas if they scored poorly, that would be consistent with a retrocochlear loss. And then the final one that we'll just touch on, all of these three tests would typically be relatively insensitive on their own, so you would expect to apply them as part of a test battery, and they only take sort of a few minutes each. And so the final one would be the alternate loudness balance test. And here, again, with an asymmetrical loss, like we were showing in the previous audiogram, then we might expect a perception of loudness, a pattern of loudness when related to the non-suspect ear, or the good hearing ear, to reveal the presence of cochlear recruitment. That would be consistent with a cochlear hearing loss, or no cochlear recruitment, which might be consistent with a retrocochlear loss. So we would play a sound to the good ear, we would then alternate the side and play the same sound to the poorer ear, and we would then modulate the sound in the poorer ear, turn it up or down, until such time as the person described the loudness as the same as that in the good ear. So we'd keep switching between the good ear and the poorer ear, and modulate the sound level in the poorer ear until the patient felt that they were equal in loudness. And often the results are expressed on a ladder chart like this. And so I'll just briefly explain the results here and how to interpret them when expressed in such a way. So on the left here, what we can see is the ladder chart pattern for someone with an asymmetrical loss like we showed. So the left ear is the suspect ear, but this is a cochlear loss showing recruitment. And so what we see is on the right ear, the normal ear, we see the loudness changing from very quiet to very loud over the normal dynamic range for someone with normal hearing of about 100 or 105 dB. But the same loudness range in the poorer ear was compressed into a physical range of only 65 dB. And this is what's meant by recruitment, an abnormal growth in the loudness. So we go from very quiet here up to loud in a much quicker or shorter dynamic range than in the normal ear over here. Now, in the middle part of the chart here, we can see that there's no recruitment because the same changes in loudness were produced over the same dynamic range in this middle case. So there's no recruitment here. This is a 60 dB dynamic range. So there was an asymmetrical loss because we can see that, for example, the same loudness for a sound just above threshold here, let's say that was 0 or 5 dB, the same loudness was only achieved in the suspect ear at an intensity of about 40 dB or so. But there's no recruitment. Whereas on the right hand side of the chart over here we can see the opposite occurring. So here we have a range of loudnesses over a 40 dB intensity range, but that same range of loudness in the suspect ear was perceived over a much wider range, over 60 dB. So this is expansion effectively, or sometimes described as decruitment, sorry. So recruitment would be consistent with a cochlear loss, and either no recruitment or decruitment might be consistent with a retrocochlear loss. Now, I would just like to close by mentioning the relationship of this ABLB to the otoneurological ABR, and I think this is important because the three tests here that I described, the tone decay, this short increment sensitivity index, and the ABLB, in terms of audiological tests, they're, perhaps it's fair to say, less popular than in previous years because of the introduction of more sensitive procedures, the MRI scan being one, but the otoneurological ABR being the other. So these tests perhaps down the pecking order in terms of their priority, but certainly this ABLB is a very important preliminary test in order to achieve the correct interpretation of the ABR, so it's well worth mentioning in that context. So here we have the same suspect audiogram here, with the left ear being the suspect ear, suspicion of a retrocochlear lesion, and the right ear being the non-suspect ear. And so what I'd like to do is just relate the ABLB to the otoneurological ABR in determining whether or not there might be a retrocochlear lesion to explain this audiogram. So normally what we do with the otoneurological ABR, one of the tests that we do is an interaural latency comparison, so the timing of the wave 5 in the suspect ear compared with the non-suspect ear. And typically it would be to a high intensity click, maybe an 80 dB NHL click sound. And these ABR traces here show perfectly normal results, because you can see the trace from the right ear and the trace from the left ear. There's no timing difference in the latency of the wave 5 there. They occur at the same time. And if you did have that compression of the nerve, the distortion and the reduced blood supply, etc., in the presence of a retrocochlear lesion, then you might expect the latency to be delayed in the suspect ear. So here we have a negative result, and here's an example of a positive result. So here we can see there's a timing delay in the wave 5 there on the blue trace corresponding to the left ear compared with the red trace. But in order to make a correct assessment as to the cause of that timing delay, then we need to have done a preliminary test, the ABLB, because there are broadly two possible causes of that delay in the left ear. Firstly, it could be a cochlear loss, and secondly, it could be, of course, the retrocochlear loss that we're interested in. And so what we need to do is we need to eliminate or correct for the latency change that might be associated with a cochlear loss, and then any further changes can then be attributed to a retrocochlear cause. And it might seem crude, but it just so happens that balancing the loudness between the ears is quite an effective way to account for, correct for any latency changes that are associated with the any cochlear cause of that loss. And so we would take that click sound, and before we measured the ABR, we would balance the loudness between the ears, and then we would proceed with the test. And it would be two different intensities in the non-suspect ear and the suspect ear, but the loudness of the click in each ear would sound the same to the patient. So here's the audiogram again. What we would do is we would do the alternate binaural loudness balancing procedure somewhere in the 2 to 4 kilohertz range. Perhaps 4 kilohertz would be a priority, and that's because in this range, this is the effective frequency range where you get the greatest neural synchrony for a click. So we would balance the loudness of the sounds using a pure tone at say 4 kilohertz. And then we would apply those values for the click. We wouldn't use the click to balance the loudness of the click itself, because of course in a sloping loss like this, you can see that the thresholds are very good in 500 hertz, for example, and below, and so there'll be a very different intensity level that you would end up with for the click sound, because the person can use the good thresholds in the low frequencies to achieve a closer balance between them. But those low frequencies aren't actually effective, especially in evoking the ABR. It's the higher frequencies, particularly in the 2 to 4 kilohertz, that evoke the ABR. So it's those frequencies that we would concentrate on. Okay, so now I'd like to just draw matters to a close, because I'm aware of the time, of course, and I'm very grateful for your attention, but just in brief summary, so we've covered high-frequency audiometry and discussed some clinical applications, particularly in terms of the concept of hidden hearing loss and tinnitus with a normal audiogram. And I think it's well worth being aware of these concepts, because these are two topics of hot discussion and debate, certainly in the research arena, and increased awareness of concepts like hearing screening amongst adults, which we might expect to see more and more widespread in the audiometric domain. Then we have the 10 test for dead regions, Stenger test for identification of unilateral non-organic loss, and then 3 subtests which can be used together to help identify for retrocochlear lesions, or as certainly in the case of the ABLB, a preliminary test in other procedures which also are relevant for retrocochlear lesions. So with that, I will just thank you again for your attention, and point you in the direction of these interesting references which unpack many of these concepts in more detail. And of course, if anyone does have any questions, I'll be delighted to try and address them now. Thank you.